higher risks of cardiovascular disease. So there is need to have a cutoff in the definition of hypertension to help us manage these patients well. I'm presenting these two definitions just to show that there are little differences when it comes to the definition of hypertension. If you take the European Society of Cardiology, optimal blood pressure is any systolic blood pressure that is less than 120 or diastolic blood pressure that is less than 80. So this you need to satisfy these two conditions to say your blood pressure is optimal. If your blood pressure is between 120 to 129 systolic and a diastolic of 80 to 84, then we say you have normal blood pressure. And note this, high normal is when your blood pressure is between 130 to 139 systolic and 80 to 85 to 89 diastolic. But this same high normal blood pressure by the European Society of Cardiology is termed as stage 1 hypertension by the American College of Cardiology or the American Heart Association. So this highlights the little differences, but irrespective of these differences, when it comes to the management, you realize that by and large, there is huge agreement in terms of how to manage patients with elevated blood pressure. Hypertension is the leading modifiable risk factor for cardiovascular disease and premature death worldwide. If you take all the risk factors that lead to death, including smoking, including diabetes, including road traffic accident, alcohol use, all the risk factors, if you put them together, hypertension is the leading risk factor for cardiovascular disease, the leading risk factor for premature death. And so it is important that we manage people with hypertension well in order to minimize this risk. Globally, the burden of hypertension is huge. It is estimated that about 1.4 billion people, now the world population is about 8 billion, we are looking at about 1.4 billion people with hypertension. And most of them are living in the low and middle income countries. About 2/3 of these people with hypertension are living in the low and middle income countries. If you look at the data that was released in 2015, 1 in 5 people with hypertension have the problem under control. What that tells you is that under control. A huge number of patients with hypertension do not have the blood pressure under control, and that is a huge problem that needs to be dealt with. Because hypertension is not a benign condition. It leads to several target organ damage and complications. It is the most common cause of stroke and transient ischemic attack. Hypertension is the most common cause of heart failure and coronary artery disease, left ventricular hypertrophy. It is one of the most common causes of kidney disease, end-stage renal disease. In addition, it causes retinopathy, it causes peripheral vascular disease. There are so many complications that are associated with hypertension. Therefore, it is important that we get this blood pressure under control. So it's sad that just about 1/5 of patients with hypertension have their blood pressure under control. If you take the Ghana situation, for instance, this study was published by Bosu in 2021, and they looked at a systematic review of all studies that had been published between 1976 to 2020. This involved about 82,000 patients, people between the ages of 15 to 100, and the pooled prevalence of hypertension was 27%. But what is instructive from this study was that only 6% of patients with hypertension had their blood pressure under control. this is not acceptable in Africa, where hypertension is the main driver for cardiovascular disease. If another important aspect was that about 65% of patients with hypertension were not even aware that they have hypertension. So diagnosis rate is low, and control rate is even worse, and there's a lot of work to be done accurately in diagnose hypertension. A lot of the times, the circumstances under which we measure blood pressure are not conducive, and if that is not ensured, then you may be measuring blood pressure wrongly. So have a good environment, very conducive environment that is not very noisy, and have the patient sit up very well, uprightly, with the legs not crossed, and then the arm bare, the patient not talking during the measurement of the blood pressure, and then at least measure the blood pressure 3 times and average the last 2 blood pressures. If you do this, then you are most likely to have a very accurate blood pressure measurement. But there are several mistakes that are made during the measurement of blood pressure. Some of these common mistakes lead to increased blood pressure at the hospital or in the office when the blood pressures are measured in office. If a patient is talking during the measurement of blood pressure, it leads to about 4 to 19 millimeter increase in systolic blood pressure. The same way if the legs are crossed, or if you measure blood pressure over clothing. Sometimes patients come, they are wearing long sleeves, and you see some of our nurses and assistants measuring the blood pressure over the clothing. It has to be on bare hand. If the cuff size is not appropriate, you are not going to get adequate blood pressure measurement or appropriate, correct blood pressure measurement. So it is important that we ensure that blood pressure is measured accurately, because that is the only way to diagnose hypertension. Therefore, let's ensure this accurately. So the American Heart Association gave some steps and checklists to make sure that you are measuring your blood pressures accurately. It says step 1 is properly prepare the patient. So the patient should not take any coffee beverages 30 minutes before blood pressure. They should not smoke any cigarette. So prepare the patient well, make sure that they are relaxed whilst we are checking the blood pressure, they are sitting upright, and all those things I spoke about. Use the proper technique for blood pressure measurement. Take the proper measurements needed to diagnose and treat hypertension. Also, properly document the accurate blood pressure reading. Sometimes we measure the blood pressure and we don't document it immediately. Then you try to document and recall from memory, and that may also be a problem. And the 5th step, very important, average the readings. You don't use one blood pressure measurement to estimate the blood pressure of a patient. Every time you are going to check a blood pressure, the general rule is that discard the first measurement, ask the patient to relax for about 2 to 3 minutes, check the blood pressure again, ask the person to relax another 2 to 3 minutes, check the blood pressure again, and then discard the first one, take the average of the last 2, and that is the blood pressure of the patient for that specific time. And always remember to give feedback to the patient when you measure the blood pressure. So having measured your blood pressure, it is then important to determine what's next in terms of what to do for the patient. If the patient blood pressure is optimal, like blood pressure below 120/80, then usually there's no need to frequently measure the blood pressure several times in the year. The recommendation that you can measure the blood pressure at least once every 5 years. If the blood pressure is normal, or is between 120 to 129 millimeters of mercury, or the diastolic is between 80 to 84, then you need to do a little bit more frequent, like every 3 years, that patient has to have the blood pressure checked. If the blood pressure is high normal, that is between 130 to 139, then these patients need further evaluation. Don't just leave them alone. And this further evaluation is what we term out of office blood pressure measurement. Either they do home blood pressure monitoring, or you do ambulatory blood pressure monitoring to be able to tell whether the patient has hypertension or not, because there are various phenotypes of hypertension that you may be missing during that time. Could it be a white coat hypertension? Could it be max hypertension? So max hypertension, people who have normal blood pressure during office hours, but when you measure their blood pressure out of office, that is home blood pressures, are high, then these persons are sent to have mass hypertension, whereas the reverse is true for white coat hypertension. So they tend to have normal blood pressures at home or out of office blood pressures, but when they come to hospital, their blood pressures are high. And these people, you need to keep an eye on them. You do not necessarily start antihypertensives, especially if there's no target organ damage. You need to keep an eye on them and then make sure that you are not missing hypertension. And there's this entity of nocturnal hypertension, where during the daytime their blood pressures are normal, but when they sleep, you are expecting that the blood pressure should dip by about 20%. But if the blood pressure does not dip that much, these patients may have target organ damage, and they may need management for that hypertension. So the indications for ambulatory blood pressure or out of office blood pressure, anytime you suspect that the patient has white coat hypertension, or you suspect that the hypertension is episodic, or the patient may be having max hypertension or autonomic dysfunction, or the patient is on treatment and you are not getting target blood pressures. All these are indications to assess for out of office blood pressure. The most common one will be the ambulatory blood pressure. But if you don't have the ambulatory blood pressure, you can ask them to do home blood pressure monitoring, teach them how to measure the blood pressure well, and then let them document 1 week blood pressure from the house, morning and evening for 1 week. And then when they come, you can help them to take the averages to see how the blood pressure is doing. Unfortunately, the home blood pressure cannot tell you about the nocturnal dipping and those ones. So if you have access to ambulatory blood pressure, then that gives you more information than the home blood pressure monitoring. So how do you evaluate a patient with hypertension? We do know that across all ages, when that systolic or diastolic hypertension, it is associated with increased cardiovascular disease, and therefore it is important to try to reduce the blood pressures. And several studies have shown that effect, and I've already mentioned that systolic of above 115 is that. In addition, hypertension does not come alone. It usually comes with other comorbidities. So patients with hypertension, 2 in every 3 patients with hypertension have a comorbidity. And 2 in every 3 patients with a comorbidity, hypertension tends to be one of those comorbidities. So if you take, for instance, patients with diabetes, about 75% of them have hypertension. Similarly, if you take patients with dyslipidemia, about 64% of them have hypertension. And therefore, these patients tend to have multiple comorbidities. And it is important to evaluate them. Don't just focus on the blood pressure, but try to have a total view of the patient to be able to manage them appropriately. So the common risk factors that you tend to see in patients with hypertension, we have those we call modifiable risk factors and those that are less modifiable. So the modifiable risk factors are cigarette smoking. Is the patient smoking, or is it first-hand smoking or second-hand smoking? Does the patient have diabetes? Does the patient have dyslipidemia, obesity, physical inactivity, unhealthy diet? So all these are risk factors that can be modified, and you try to identify them and modify them appropriately. And those that are less modifiable include chronic kidney disease. If the patient has moderate to severe chronic kidney disease, it has an impact on your management of hypertension. Family history, age, low socioeconomic status, and all those. These are less modifiable risk factors or non-modifiable risk factors. But it is important to have a full assessment of your patient. In addition, you need to do some basic or routine investigations to help evaluate the patient well. And this include the hematocrit level or hemoglobin level. You also need to do fasting blood sugar, or you may do hemoglobin A1C levels. You need your lipids. It may be fasting or non-fasting lipids, and these are important to help calculate your cardiovascular risk. Also need the renal function test. BUG and creatinine results. Uric acid is also another important test that needs to be done, as well as liver function test and urinalysis to try to look at if there any protein in the urine dipstick, or urine ACR, albumin creatinine ratio. Is there evidence of proteinuria? All these are important information you need in managing your patients with hypertension. In addition, you need to ask the patient have any hypertension-mediated organ damage, what we use to term target organ damage. And this will help. To be able to do this, you need certain investigations like ECG. If you did ECG and a patient has evidence of left ventricular hypertrophy on the ECG, the management of that hypertension is different from somebody who does not have any left ventricular hypertrophy. I've already mentioned urine albumin creatinine ratio, and then the kidney function. The fundoscopy, for instance, hypertensive changes in the retina. If that is there, then this person already has organ-mediated, hypertension-mediated organ damage, and that the person needs further care. Echocardiography may be indicated. It's more sensitive than ECG in picking up any structural changes on the heart, and then also left ventricular function. Is there any problem with that? Carotid ultrasound. Look at the intima media thickness. Look at the any carotid plaque. This not every patient with hypertension would need this to be done, but if you suspect that this patient may need it, it is important to do this. There are other further investigations like ankle brachial index, abdominal ultrasound if you are suspecting renal artery stenosis. So there are further assessments that can be done to help evaluate your patient well and then risk stratify them. But the whole point of your evaluation is to try to say this patient with hypertension, what is the person's risk level? Is this person low risk, intermediate risk, or moderate risk, high risk, or very high risk? Generally, every patient or any patient with hypertension who has established cardiovascular disease, who has target organ damage, like has coronary artery disease, has CVA, has severe kidney disease. This patient is a very high risk patient. Similarly, every patient with grade 3 hypertension, even if they don't have any other risk factors, because of the very high blood pressure, has a high risk of cardiovascular disease. So your approach to these patients will be different from those who are in stage 1 hypertension, who do not have multiple risk factors. It is also known that if patients have multiple risk factors, then it increases their risk of cardiovascular disease. So this table is a very nice summary of all that we have said to try to risk stratify your patients with hypertension. Is this person low risk? Is this person moderate risk? Is this person high risk or very high risk? And that helps you to now set targets for your management of this patient, and then the kind of medications to use to try to also reduce the risks of the patient. And remember, I said that every 10 millimeter increase in blood pressure is associated with increased risk. The same way within the hypertension range, every 10 millimeter reduction in systolic blood pressure or a 5 millimeter reduction in diastolic blood pressure is associated with benefit. And some of these benefits include reduce up 20% reduction in major cardiovascular events, about 15% reduction in all-cause mortality, 35% reduction in stroke, 20% reduction in coronary artery events, and 40% reduction in heart failure. So treating hypertension is not just about reducing numbers, it's about preventing outcomes. And that is very, very important. And irrespective of whatever is used, it helps. There are two major approaches in the management of hypertension: lifestyle changes and medication use. At every level of hypertension, stage 1, stage 2, stage 3, grade 1, grade 2, grade 3, high risk, low risk, lifestyle modification is important, and you need that lifestyle modification for all your patients with hypertension, whether they are low risk or high risk. In addition to that, patients who have grade 2 or grade 3 hypertension, in addition to the lifestyle modification, need immediate initiation of antihypertensive medications. And that is important to note. So if your patient's systolic blood pressure is 160 millimeters of mercury or above, you have verified that this patient, in addition to lifestyle modification, you need immediate initiation of antihypertensive medications. And your target is to be able to bring that blood pressure to target within 3 months. Where we have room for just lifestyle modification and later initiation of medications is when you are dealing with stage 1 hypertension. So for patients with stage 1 hypertension who do not have evidence of target organ damage, or who do not have evidence of hypertension-mediated organ damage, these patients, you can advise them to have lifestyle modification for about 3 months to 6 months, reassess the blood pressure, and if it is still high, then there is need to initiate antihypertensive medication. So this is the general approach to managing hypertension, and that is very, very important. Systolic blood pressure above 160 or above, in addition to your lifestyle, you need to start them on antihypertensive medications. And the lifestyle, there are several components to the lifestyle modification. You need to advise them to lose weight, and this involves a whole lot. You cannot do it alone. You need the dietitian, you need them to have regular exercise to be able to lose that weight. And every 1 kilogram loss in weight is associated with a 1 millimeter drop in blood pressure. And therefore, if you are able to target about 5 to 10 kilograms weight loss, you're already reducing the systolic blood pressure by about 10 millimeters of mercury. And that is very, very significant for hypertensive patients. Healthy diets, like the DASH diet, dietary approaches to stop hypertension, reducing salt intake, increasing your vegetable and fruit intake. These are very important. Using whole grains rather than the refined grains are very, very important. And also enhancing the intake of dietary potassium, like foods that are rich in potassium. And generally, the fruits like banana and other things tend to be rich in potassium, and they are also beneficial for your patients with hypertension. Also, physical activity, it could be aerobic activity, it could be dynamic resistance activity or isometric, all of them, and combination of all of them is important. Usually, you need about 150 minutes of physical activity per week to be effective in reducing your blood pressure. Even if the physical activity does not result in weight loss, it is still beneficial in terms of cardiovascular outcomes. And if the patient cannot do physical activity every week or every day of the week, even the weekend busters tend to benefit from cardiovascular outcomes as well. So 150 minutes per week, you could divide it into 30 minutes every day for 5 days, or you could do 1.5 hours in the weekend, or 1 hour on Saturday, 1 hour on Sunday. You have achieved your targets, or almost achieved your target. And then another important aspect is moderation in the use of alcohol. Now, the evidence is not controverted. In fact, there were confusion about, oh, a glass of wine is good for your heart and all those. And now, the World Health Organization website is well written there. No amount of alcohol is safe for our heart. So if the patient does not drink alcohol, you do not tell the patient that, oh, take a glass of wine to help with your alcohol. Those who drink alcohol, if they can stop, it is better for them to stop. And then if they cannot stop, then insist on moderation. But it is better that you do not take alcohol, especially if you are struggling to control that blood pressure, because it does not benefit your cardiovascular outcomes. Then when it comes to the medications, there are several medications that are available in controlling blood pressure. Diuretics, calcium channel blockers, ACE inhibitors, ARBs, mineralocorticoid receptor antagonists, alpha blockers, vasodilators. There are several of them that are available, and it is important to know which ones you can choose for your patients and what are the various indications. But whatever it is, if you look at the 2017 ACC guidelines, they stated clearly, and the 2018 ESC guidelines, the 2020 ISH guidelines, all of them are stating clearly. And what they say is that the amount of blood pressure reduction is the major determinant of reduction in cardiovascular risk in both younger and older patients with hypertension, not the choice of antihypertensive. So your first target is to reduce the blood pressure. It is not about the choice of antihypertensive, but in addition to reducing the blood pressure, then you think about other specific benefits in terms of classes and other specific agents. But whatever it is, reducing the blood pressure is the main driver of the cardiovascular benefits that we see in patients with hypertension. If you take a look at the all-heart trial, this is a very old trial. I think it was done in 2002. About 33,000 patients were involved in the all-heart trial. They set off initially to compare 4 antihypertensive classes: thiazide, calcium channel blocker, ACE inhibitor, and then they also added alpha blocker. But they had to drop the alpha blocker because there was a worse outcome with alpha blocker during the midterm analysis. But for those on these 3 agents separately, like the thiazide, calcium channel blocker, and the ACE inhibitor, the outcomes were similar. There was no difference in outcomes. So it goes to buttress the point that whatever agent you use to reduce the blood pressure, that blood pressure is the main driver of cardiovascular outcomes. And it is important to remember that. But we do know that a lot of patients will need more than one agent to control the blood pressure. So there is need to combine agents to be able to achieve the blood pressure target. Majority of your patients will need about 2 or 3 antihypertensives to be able to control the blood pressure. And many combinations are possible for your patients. There are several benefits that are associated with combination therapy. Usually, they tend to have different mechanisms and therefore get you a better blood pressure control. In addition, some of them, the side effects counteract each other, and therefore patients are able to tolerate them better. For instance, if you combine a RAS inhibitor with a calcium channel blocker, it tends to reduce the pedal edema that is associated with calcium channel blocker. The same way, if you combine a diuretic with an ACE inhibitor, for instance, or a RAS inhibitor, then the potassium increase that is associated may also be reduced. So you try to use these combinations and achieve this synergistic effect of these combinations. That is why the combinations tend to work better than the monotherapy. So the main combinations that are available, remember that you cannot combine ACE inhibitors and ARBs. So you either choose an ACE inhibitor or an ARB. And these can be combined with either a diuretic or a calcium channel blocker or a beta blocker. And there are several combinations that are available. The general principle is that you start with a dual combination. I think I'll get there very soon so that I don't belabor the point. If you take a look at the accomplished trial, and this also compared various combinations. ACE, let me put it this way, ACE inhibitor diuretic combination versus ACE inhibitor amlodipine combination or calcium channel blocker combination. So they were looking at amlodipine or calcium channel blocker based combination versus diuretic based combination. Both groups had ACE inhibitor in it. And I mean, for those of us who know, they were looking at the cardiovascular outcomes, and it turned out that if you take a look at the amlodipine based combination, gave them a better outcome, a greater benefit compared to the diuretic based combination for dual combination therapy. And this was also corroborated by the Crowley trial in Africa. And this study was done in Africa. They were comparing 3 different dual antihypertensive combinations. So you're looking at calcium channel blocker diuretic, calcium channel blocker ACE inhibitor, and then diuretic ACE inhibitor combinations. And this, the main outcome they were looking at was blood pressure variability. How stable is the blood pressure control, or what is the level of variability in blood pressure control? And if you take a look at it clinically, they did 24-hour blood pressure monitoring for these patients, and ACE inhibitor plus that thiazide diuretic combination showed higher levels of ambulatory and within clinic BP variability than the calcium channel blocker containing combination. In other words, amlodipine based combinations tend to have more stable blood pressure control than the diuretic based combinations when you are looking at 2 combinations. So for Africans, any combination, if there's no contraindication to the use, then calcium channel blocker should be one of your preferred combinations, in addition to all the others that may be added to it. And if you take a look at the various single pill combinations that are available, so this takes a look at several trials that have been done. If you take a single pill tablet compared to its individual multiple tablets, patients tend to get better control when they take a single pill tablet than when they take these tablets in multiple combinations. For instance, if you have a combination of, let's say, calcium channel blocker plus ACE inhibitor or ARB in a single tablet versus giving them in single doses, those taking the single tablet tend to have better control than those who are taking the individual's components. And this is partly because there is better compliance when you are on the single tablet combination. So with all this information I've given you, it informed the new guidelines for the management of hypertension. if you take a look at the 2018 European Society of Cardiology guidelines, this is the core treatment strategy for uncomplicated hypertension. And they say that for initial therapy, it should be dual combination therapy, either an ACE inhibitor or ARB plus a calcium channel blocker or a diuretic. And this should be in a single pill tablet. So we are not saying that, right, for instance, amlodipine and valsartan or amlodipine and losartan, whatever, as separate tablet, but in a single tablet combination therapy. And this should be your strategy for the majority of patients with uncomplicated hypertension, except a few patients who are frail, who are very old, where you may consider the initiation of monotherapy. Otherwise, for the majority of your patients, dual combination therapy is the strategy to adopt. And then step 2, if your blood pressure is not well controlled, change this combination to a single pill triple therapy. So we still insist that even when we are using 3 antihypertensive medications, it should be in a single tablet. And this, the combination is ACE inhibitor or ARB plus a calcium channel blocker plus a diuretic. And there are several combinations that are available, and a single pill combination is preferred. If at this stage patient is not well controlled, then there is need to add another tablet, because you are now entering into the realm of resistant hypertension, and therefore there is need to add others. But the note here is that beta blockers can be used at any stage of hypertension depending on the indications. So if the patient has ischemic heart disease or the patient has heart failure, then you are not going to say that I'm going to wait till I get to resistant hypertension before I bring in a beta blocker. It is important to know those nuances. And this combination is similar to the NICE guidelines. 2019 NICE guidelines, the same combinations were given. So in all this, you do not combine ACE and ARB, but it's a similar combination that was given in the NICE guidelines. If you take a look at the 2020 International Society of Hypertension guideline, this is a global guideline that involves a whole lot, and it is the same recommendation that is being given, and that they say that it should be preferably single pill combination therapy and start with a dual antihypertensive therapy. So you have A is an ACE inhibitor or ARB, plus C is a calcium channel blocker. So they went straight for the most effective combination, ACE or ARB plus a calcium channel blocker as your initial tablet. You start from half doses. If they are not well controlled, increase them to the full doses. If the patient is not well controlled, at this stage, you need to add a diuretic. It should also be in a single pill tablet. But they also put essential information here that whatever is available can be used. So don't say that I do not have a single pill combination, therefore I'm not going to prescribe. It is important that you make sure that the patient receives the therapy, and that is what is most important for this patient. And now the latest guideline that was released was the European Society of Hypertension guideline that was released in 2023, and there was not much change when it comes to the combinations that are prescribed. So start with dual combination therapy in most patients. And this dual combination therapy is the same thing I've mentioned to you, ACE or ARB plus a CCB or plus a diuretic. And if you do dual combination therapy, start from half dose. If they are not controlled, increase to full dose. You will get about 60% of your patients with hypertension achieving target. If you do not achieve target, you convert to single pill triple therapy. And with single pill triple therapy, you are likely to have up to 90% of your patients having control. And this will be a far cry from the 6% control rates we are talking about. So it is important that we follow the guidelines. The 10% or so, or up to 5% of patients who will be diagnosed with resistant hypertension, these patients will be needed to refer to the cardiologist or the hypertension specialist to then evaluate them for further care and management and proper control of their hypertension. So this is a very important strategy that can help us to achieve better control. When it comes to target to achieve the European guidelines, for majority of your patients between the ages of 18 to 65, you target 130, below 130 systolic, but not below 120. You are good to go, except for a few caveats there. But for the majority of your patients, if you target below 130 systolic, and so don't be happy with, oh, blood pressure is between 130 to 140, so I'm okay. We want to bring it down to below 130, but don't be overly aggressive to cause hypotensive episodes. And for diastolic, we want to maintain between 70 to 80 millimeters of mercury. And this is similar if you look at all the guidelines that have been published, both the American guidelines and the European guidelines. There are similarities when it comes to the management of hypertension. The use of ambulatory or out-of-office blood pressure is important. The use of cardiovascular risk assessment to totally reassess your patient is very, very important, and then when to initiate therapy. The little differences are to do with the targets to achieve depending on specific associations, like if the patient has CKD, if the patient has diabetes, but generally you will not be wrong if you targeted less than 130 over 80 for majority of your patients. That will be a good target to aim at. So what are the practical approaches to control hypertension? Accurate BP measurement for accurate diagnosis, very, very important. Risk stratification involves good history examination and investigation. So don't just prescribe BP medication. What other risk factors does the patient have? All patients require lifestyle modification. Determine who can have 3 to 6 months of trial of lifestyle modification alone. And I've stated that this is only applicable if the patient has grade 1 hypertension without hypertension-mediated organ damage, without target organ damage. If the patient already has target organ damage and the blood pressure is about, let's say, 135 over 84, you have no business saying that I'm just doing lifestyle modification. That patient needs immediate antihypertensive medication in addition to the lifestyle modification as well. Most patients should be initiated with single pill dual therapy at low doses, and usually the rough guide is that start from half the doses and increase, review them in 2 to 4 weeks. If the blood pressure is not on target, increase them. One of the biggest challenges we have in adequate blood pressure control is the inertia from physicians, and let's try to kill that inertia so that we can help our patients well. If they are not on target, don't be inertia, move to the next stage. If you have them on single pill triple therapy and the blood pressure is still not on target, you know that these patients, about 90% of them will have blood pressure control. So if it is not, then you need to reassess your patient. Are they complying with the medications, or is it a white coat effect? So you need to do out of office blood pressure measurement to also assess them, and then also assess them for secondary causes of hypertension. These are the patients you need to refer to the cardiologist, you need to refer to the hypertension specialist to do further care where there is need to, and depending on your potassium levels, choose other medications. But by and large, most of these patients would need a narcotic receptor antagonist as an addition to your antihypertensive medications. So how do we improve hypertension management? It is our responsibility as prescribers to adhere to the protocols when prescribing antihypertensives. If we do adhere to these protocols, majority of our patients will get control and the story will change. It is also important to include affordable single pill combinations in the essential medicines list that will pave the way for this medication to be included in the national health insurance so that patients who cannot afford them will be able to have them. Guidelines on tax shifting and tax sharing is also important. Screening of hypertension, refill of medications. Do patients always need to come to the hospital to have their medications refilled? I don't think so. What can our cheap compounds do? What can our health centers do? If we get them under good control, can they continue refilling their medications there? Do they still need to see the teaching hospitals and the specialists? No. So these are ways we can reduce the burden on the physicians and the cardiologists so that they can concentrate their attention on the few that are not getting their blood pressure controlled. So in conclusion, hypertension is the leading risk factor for cardiovascular mortality. There is need to measure your blood pressure accurately because that is the only way to diagnose hypertension and the only way to monitor your patients with hypertension. There is need to do a global risk assessment for your patients with hypertension. Don't just focus on the hypertension, the blood pressure, the numbers, but look at the total cardiovascular risk of your patient and manage them appropriately. Some of them you need to, in addition to hypertension, manage their diabetes, manage cholesterol, reduce their weight and all those things. So look at them in totality. Lifestyle modifications are an essential part of blood pressure management at all stages of hypertension. And just know that most of your patients will need dual antihypertensive combination therapy as the initial treatment for hypertension. Thank you very much.
So much, Dr. Kumba. Was an excellent presentation. Really appreciate it. Thank you so much for that. I think we'll take questions at the end of the second presentation. So let's just hold our questions, but I know we have a lot to ask. In the meantime, I would like to invite my colleague, Dr. Angela, to introduce the next speaker. Thank you very much, Dr. Chikun.
You're welcome.
Angela, you're muted. We can't hear you.
Sorry about that. So Dr. Yusuf Zubair is a consultant neurologist and serves as Deputy Director of Medical Services at the Defense Intelligence Agency Hospital Asokoro in Abuja. He's also a fellow of the West African College of Physicians. Dr. Zubair is a proponent of continuous professional development. He's had specialist training in EEG, EMG machines. He's participated in European Stroke Conference, American Academy of Neurology annual meetings, and various congresses, both locally and internationally. His academic contributions are equally impressive. He has multiple publications and abstracts, which he's presented both locally and internationally. And his main research focus is on movement disorders, Parkinson's disease, and their relationship with biochemical markers. He's made a lot of impact in the community, both in providing free medical care, and he's deeply invested in brain health and management of neurological diseases, hypertension, and DM. His career is a testament to his unwavering dedication to medical excellence, his passion to continuous learning, and his commitment to serving both his immediate community and the broader medical field. So, Dr. Zubair, over to you to give us your presentation. Thank you.
Dr. Angela, for the brief introduction. So I'll be sharing my slides. Okay. I hope everybody can see my screen.
Not yet.
Still not yet, because it's showing on my side.
No, maybe you stop sharing and then reshare again. So.
Okay, I'll do that. How about now?
Not yet.
Really?
No, not yet.
It's already showing on my side. What's the problem?
Maybe it's a network, or do you want me to?
Okay,
Do you want me to share? Okay.
Let me just try one more time.
Okay.
And Dr. Zubari, if you don't mind, please, we'd like to have your video on so that the attendees can also
My
see
video is
your...
on.
Oh, wow.
You can't see me.
We can't. No, we can't see it.
No, we can't.
You can't?
No, we can't.
Oh. Yeah, let me turn it on and off again.
Okay.
How about now?
No, not yet.
Really? Well, you can hear me.
Yes, we can. Or do you log off and then log back in?
Okay, maybe I should try that.
Okay.
Well, okay, because I'm just thinking of the time. We can share from our side. Okay, but he has logged off. That's okay.
Okay.
Am I back on?
Yes, we can see you now. We can see
Yes,
you
it's
now.
better now.
Okay, so I guess, so let me share the slides now. So, can you see the slides now?
Oh, yes, we can. Go ahead, sir.
Okay, great. Sorry for the mix-up. So, like Dr. Angela said, I say thank you for the introduction. My name is Yusuf Zubair. I'll be talking briefly on updates in management of epilepsy. And this is a disclaimer from Novartis. The following presentation may contain scientific, medical information, non-approved dosages, indications, currently under clinical investigation or scientific review. Kindly note that the views and opinions of the speaker do not necessarily reflect those of Novartis. Novartis recommends the use of their products only in strict accordance with the locally approved package inserts. And this goes to my own disclosures. I have none to disclose. So our learning objective this evening will just be about 5 points. We understand the evaluation of a patient with seizures, the clinical classification of seizures and epilepsy, the essential investigations of a patient with epilepsy, the choice of anti-seizure medication, and what do we do when medications do not work? That's beyond medication therapy. So by brief introduction, epilepsy is derived from the Greek word epilepsia, which means upon, with lepsis, which is to take hold of or to seize. In early Europe days, it was misunderstood as demonic possession. I think that has not changed even in the present day Africa. People still think epilepsy is a demonic possession. Seizures is one of the most common neurological problems. The epilepsies are a diverse group of conditions that share a predisposition to recurrence of unprovoked seizures. Majority of patients have cognitive, psychiatric, or medical comorbidities, which must be appropriately diagnosed and treated. So it's important to identify epilepsy type, the syndrome, the etiology, because these are critical for choosing cost-effective, high-yield investigation, optimizing therapy, and understanding the prognosis of epilepsy. By way of epidemiology, epilepsy affects about 60 million people worldwide. About 10% of the population will experience a seizure in their lifetime, and approximately 1 to 26 people will develop epilepsy in their lifetime. The incidence is about 50 to 100 per 100,000 individuals per year, and is high in extreme ages and low-income countries like Africa, and we understand why. Infections is a major contributing factors to that. Now, it's important to differentiate seizures from epilepsy, or rather to understand what seizure and epilepsy means. So seizure is a brief and is usually unprovoked. It's unprovoked, it's stereotyped. That means every time it happens, is similar. Disturbance in behavior, emotion, motor function, sensation, which results from abnormal excessive electrical discharges from the cerebral neurons. So what is epilepsy? Epilepsy is recurrent paroxysmal disease of the brain function due to abnormal and excessive discharge of the neurons. Simply put, a seizure is the event, and the epilepsy is disease associated with spontaneous recurring seizures. What that means is that when there is seizure, you can have the seizure, but for you to have epilepsy, you must be having recurring seizures. So epilepsy, according to International League Against Epilepsy, defines epilepsy as a disease of the brain by any of the following conditions. That is, at least 2 unprovoked seizures, meaning there should be any remote cause at the point when there is a seizure, and it must occur 24 hours apart. Means if you have seizures 3 times a day, it's not an epilepsy. And when we say one unprovoked seizures, the first thing is that you must have 2 unprovoked seizures, and they must be 24 hours apart. The other thing that is, if you have 1 unprovoked seizure, there must be a probability of further seizures, which is similar to the general recurrence of at least 60% after second unprovoked seizures, occurring over the next 10 years. Let me explain. Meaning, if you have a seizure, there must be something that is recurring that can cause a second seizure for you to say there is epilepsy. That means you can diagnose epilepsy when there is a seizure, and you see other things by doing investigation and find things that can make the seizure reoccur again. Then you can say the person has epilepsy. The third thing is that when the person has epileptic syndrome, meaning there's seizure, there are EEG findings, and there are other manifestations of the syndrome, then you can say the patient has epilepsy. Epilepsy is considered to be resolved for individuals who have had age-dependent epilepsy syndrome, who are now past the applicable stage. For example, there are some neonatal seizures that only happen when you are neonate. Immediately you pass the age of neonate, the epilepsy is gone, and it's gone forever. The other thing is that we say a patient is seizure-free for at least 10 years with no seizure medications for at least 5 years. Now, the important thing about epilepsy in trying to make treatment is making a diagnosis. And I think this lecture will just focus more importantly on how you make a diagnosis of epilepsy and how you choose the appropriate medication for it. So we'll be answering about 6 questions in trying to make the diagnosis of epilepsy. The first thing is that, is it a seizure or a non-epileptic event? Is the seizure provoked or is unprovoked? Is the unprovoked seizure epilepsy or epilepsy? What type of epilepsy are we dealing with? What is the etiology? And what are the associated comorbidities? If you can answer this question, then you can treat the epilepsy appropriately. So in answering the question of is it seizure or non-epileptic event, history is the most important thing. And history must be taken from the patient or an eyewitness. Those are the most important people in differentiating if it was a seizure or not. And the pointers to seizure are that there can be an aura. That is a feeling that you have before the seizure happens. And there are other things. There can be tongue bites. And most times the tongue bite must be lateral. If it's frontal, it's not likely to be a seizure. Incontinence is another thing. Skin color change and bruises on the body are pointers to seizures. Then most times there's a post-ictal event. That means after the seizure, there are things like confusion, post-ictal sleep, focal weakness, or speech problems after the seizure that might last hours after the seizure. Now, it's important to identify the common differentials of a seizure or common mimics, and I've differentiated them here based on age. neonate early childhood. You can have benign sleep myoclonus, whereby the patient is sleeping and is having jerks. And when you wake the child up, the jerk stops. When the child is jittery, breath holding spells, Sanderfeld syndrome, stereotypes, benign paroxysmal vertigo, cyclic vomiting, daydreaming, parasomias, that is sleep tremors, trip sterors, are also differentials or mimics for seizures. Now, when you're going from childhood to adulthood, there are tics, REM sleep disorders, postural orthostatic tachycardia syndrome, whereby it only happens when the patient is standing and he falls. You can have periodic leg movement in sleep. This only happens in sleep. There's like epilepsy, where the patient just falls off and sleeps off. So migraines, especially hemiplegic migraines, can also mimic seizures. Then you have the important one, which is psychogenic non-epileptic spells. These are common in young females, whereby they have some psychiatric manifestation and you think they have seizures. But in such patients, they never bite their tongue, they never injure themselves, and the seizures last a long time, and it doesn't respond to anti-seizure medications. Then you have episodic ataxia, periodic leg movement in sleep. These are all mimics for seizures in childhood to adulthood. Then the ones that occur at any ages, like transient ischemic attack, like vasovagal syncope, whereby the patient feels fainting, falls to the floor, but recovers almost immediately, as against a seizure where there is a long post-ictal event, cardiac syncope, long QT, and the neurogenic syncope. So like I said, the first step is identifying, is it a seizure or not? Now you've identified that it's a seizure. Is it provoked or unprovoked? What we mean by provoked, we mean acute symptomatic seizure. That means there is an identifiable remote cause around the seizure. Example is when you take drugs, toxins, or metabolic factors like hyperglycemia, hypoglycemia, hypercalcemia, hyponatremia. These are all remote causes of seizure, and the person can seize multiple times because of these metabolic problems. The other thing about provoked seizure is that it's usually generalized as opposed to focal seizures. And there is usually an abrupt cessation of a medication or drug abuse. The other times you can have provoked seizures are patients with diabetes, like I said, when you have hypercalcemia, hyper or hypoglycemia, and CKD patients. Then when you have acute event like stroke or traumatic brain injury, it's important to note that stroke can cause provoked seizures, and it can also cause epilepsy. At the point when the stroke happens, you can have provoked seizure because of the acute event of the stroke. But if it occurs after 2 weeks after a stroke, then it's likely going to be post-stroke epilepsy, because it's no more a remote cause and it's a permanent cause in the brain. Now, after answering the question of is it provoked, so is it unprovoked seizures? Yeah, the first time a patient presents to the hospital, the most time presents with convulsive seizures. That's what brings them to medical attention. But if you probe well, there might be times that there have been other manifestations of seizures, which are non-motor manifestations that have occurred that went unrecognized. So most time when they are presenting to the hospital, you might think it's the first unprovoked seizures. Rather, it might be the second or third, because they might be having episode of unresponsive tearing, isolated quick body jerks, or even nocturnal seizures. In any way, when there is a nocturnal seizures, meaning seizures that occur in sleep, we assume it's not the first time, because you can never tell if the patient has had it before. So for nocturnal seizures, we assume previous seizures that occurred. So when you have nocturnal seizures, it's most likely an epilepsy. Now, if you have made the diagnosis that this is an epilepsy, the next thing is what type of epilepsy are we dealing with? And the new classification divides them into 3 types. That means focal, generalized, or unknown. When it's focal, that means it's starting from the region of the brain or one hemisphere. When it's generalized, that means it engages the bilateral brain network from onset. And if it's unknown from your history, that means you can't get where it is coming from. So you just label it as unknown. Now, this is the classification I was talking about, the 2017 classification. And basically, it divides them into 3. There's focal onset, there's generalized onset, and unknown onset. This is an expanded version of it. Yeah, but when you are focal, it's either aware or impaired awareness. That means this patient knows the seizure is happening, or the patient is unaware of it. and it can be motor and non-motor. In motor, you can have a tonic, clonic, myoclonic, or tonic. And in non-motor, there can be autonomic, behavior arrest, cognitive, or sensory. And for focal, it can also be focal. It starts focal and it becomes generalized. And this is called focal to bilateral tonic-clonic. The second classification, the second group is the generalized onset. That means the seizures start generalized. And it can also be motor or non-motor. The common motor is the tonic-clonic, and there can be tonic, there can be clonic, there can be myoclonic, there can be atonic. And the non-motor, the commonest is absence, whereby the patient stares and is unaware of his environment. And it can be unknown, whereby history doesn't tell you where it's starting from. It can only tell you that the patient was just checking. He didn't know when he started, they can't tell. It did start from one side, they can't tell. So in such patients, you label as unknown onsets. Now, if it's epilepsy, what type? So like I said, the second classification, this is the first. The first one is the one that tells you about the seizure types. Is it focal onset, generalized onset, or unknown? Then this epilepsy type, is it focal or generalized, or it can be combined, like in Lennox-Gastaut, where you have both focal and generalized seizures. And it can be unknown if you still don't know which side of the brain it started from. The next thing is the epileptic syndrome. That's the third level of classification. And epileptic syndrome simply means cluster of clinical and EEG features that may be supported by specific etiological findings. They're actually age-dependent presentation and specific comorbidity. There are mainly three types. There's the developmental epileptic encephalopathy, which affects development of children. An example is Lennox-Gastaut. There can be Dravet syndrome too. Then the second group is the idiopathic generalized epilepsy, whereby you have absence is the typical example, childhood absence seizures, juvenile myoclonic epilepsy is another example. And you have the self-limited focal epilepsy of childhood. This is the kind of epilepsy that is self-limited. Even without treatment, when you get to a specific age, you tend to stop. An example is the neonatal focal epilepsy. So after knowing the type of epilepsy, the next thing to know is what is the etiology. And the etiology is also in 6 types. It can be structural, whereby stroke, trauma, tumors can be found. It can be genetic, whereby you have some single genes that are affected, like the KCNQ2. It can be infectious, which is the one that is common in Africa, neurocystosarcosis, HIV, cerebral malaria, the sickle, and the CMV virus. It can also be metabolic, whereby you have hypoxic ischemic encephalopathy, euphoria, and the glycogen disorders can also be in this group. Then the immune, where you have immunopathies, the Ramson's syndrome, or the glutamic acid carboxylate 65 associated epilepsy is another type. The other type, the last type or etiology, which is common in about 1/3 to half of patients, is the unknown. Because in this group, you can, with all investigation, you might not find out what is causing the epilepsy. Now, after finding out all this and making a diagnosis of epilepsy, you now need investigation. Investigation are EEG, neuroimaging, which can be CT or MRI. We'll talk about that. The metabolic screen, fasting blood sugar, calcium, liver function tests, renal function tests, magnesium. All these are trying to look for secondary causes or look for side effects of medication, the drug level. And there is this thing about role of prolactin, whereby you take the prolactin level after a seizure to tell if there was a true seizure. Now, for the investigation, the objectives. To confirm the diagnosis, you need an EEG, but most importantly, clinically, you can make a diagnosis of epilepsy clinically if you have 2 unprovoked seizures. To exclude pseudo seizures, you need an EEG, you need video EEG, or CCTV to actually look at the patient when he's having the seizures. Then for accurate classification, you might need an EEG again, like I was saying earlier, genetics, imaging. Then to determine the etiology, you also need imaging, biochemistry, hematology, and to monitor compliance, you need the drug levels or the seizure charts. So for investigation, the most important investigation that needs to be done is EEG, which is essential for diagnosis. The importance of EEG is that it assists in the determination of the seizure and the epilepsy type. It helps you to choose further investigation, and it tells you about the risk of seizure recurrence. Now, the other thing is that EEG should never be used to make a diagnosis independent of clinical context of the seizure. This simply means that seizure is a clinical diagnosis. You can't use an EEG, but EEG can support your diagnosis. The only time EEG can make a diagnosis of epilepsy is whereby you have an electrographic seizures, meaning you have seizures while you are doing the EEG. Then that can be a diagnostic of epilepsy. So these are examples of some epilepsy, unique signatures in epilepsy. These are EEG pictures, EEG tracing. The first one on the right corner, you can see the epileptic fault discharges. These are epileptic discharges with my cursor. They are pulley spikes and waves. And this is typical of juvenile myoclonic epilepsy. This is the common absence seizures where you have 3 head spikes and wave discharges. When you count, you have 1, 2, 3. So for every second, you have 3. So this is 3 heads, spike and wave discharges, and it's typical of absence epilepsy. Sorry. The third one, this is centrotemporal spikes that are recorded in childhood epilepsy with centrotemporal spikes. These are centrotemporal spikes. These spikes here, they are the center, so they are called centrotemporal spikes. Now, the next investigation is neuroimaging, and it's essential to identify underlying structural lesions, which may make control very difficult. The neuroimaging of choice is actually MRI, because these are the ones that can identify subtle structural lesions. CT can investigate acute neurological events like trauma or in unconscious patients. But it's important to note that it's best to do an MRI when you have a patient with epilepsy than a CT, except it's an acute event whereby you need diagnosis very fast, then you can do a CT. But for evaluation of epilepsy, MRI is actually the image of choice. Now, what's the difference between MRI and a CT? MRI that avoids radiation exposure and enhances the detection of lesions. CT has a low sensitivity for detecting small cortical epileptic form lesions. Low-grade gliomas cannot be picked by CT. Cavernous malformation cannot be picked. And more importantly, lesions in the base of the skull are not picked by CT. So anytime you have a patient that is suspect epilepsy, please, it's better to do an MRI than a CT. Anyway, this is an example of a CT. This is a bleed in the frontal region causing epilepsy. These are 2 MRI images. The one on the left, you can see hippocampal hyperintensity. This is it. This is what causes mesial sclerosis, and is actually resistant to medication. If you can compare, this is the right, this is the left. If you see the left, you can see atrophy. You can see this hyperintensity. This is what is causing the seizure, which is not on this side. For the other image, these are hyperintensities in the occipital lobe. On biopsy, this is this embryoplastic neuroepithelial tumor, which is also a cause of epilepsy. So like I said, the most important imaging investigation is an MRI. If the patient is not unconscious, please, it's an MRI that is important for the diagnosis of epilepsy. There are sometimes that you might need to do other investigation that we call functional imaging. These are meant for surgical patients. That is when the patient is not responding to anti-seizure medication. You might need to do a positron emission tomography to identify areas of hypometabolism, or you do a single photon emission tomography to identify areas where there are increased blood flow, or a magnetoencephalography for functional imaging, or neurophysiologic examinations. So these are the ones you do for patients that are resistant to medication. Now, when we talk about the goal of management, what are our goals of management? The most important thing is freedom from disabling seizures, minimizing therapy-related side effects, prevention and treatment of comorbidities, and prevention of sudden unexpected deaths in epilepsy, and maximize quality of life. Now, this is actually very important. It's important to know what you do when a patient is seizing or a patient is having a seizure. Stay calm and make sure someone is in charge. Make sure the patient is lying down in a safe location. Clear all obstacles away and place something soft under the head of the patient. Quickly assess for ABC, airway, breathing, and circulation. Roll the patient to his or her side. Rotate the head far enough to allow saliva and to clear the airway. Do not attempt to put anything in the mouth, tongue, blade, or spoon into the mouth of the patient during the seizure. Do not pour water or any oil or liquid at all. If outside the hospital, get the patient to the ER in 3 conditions. If it appears that the seizure was the first time, if the seizure lasts more than 4 to 5 minutes, or if there is indication for acute medical problems, maybe trauma during the seizure. Now we'll go to treatment. After identifying what epilepsy we are dealing with, is it focal, is it generalized, or is it unknown? And we have done the investigations, EEG, neuroimaging, and blood workup. The next thing is treatment. And the treatments are just 4: anti-seizure medications, surgery, neuromodulation, or diet. Now, talking of anti-seizure medication, this is the mainstay of treatment. And an ideal anti-seizure medication is supposed to be broad spectrum, no side effects, and works for all age groups. Unfortunately, they are not ideal medications. Also, all anti-seizure medication can prevent seizure occurrence, but none of them is proven to have anti-epileptic genetic effect in humans. That means they can only prevent the recurrence. They don't cure the disease. So choosing an optimal anti-seizure medication for an individual patient is becoming a daunting task as more and more drugs are approved daily. Now, the principles of anti-seizure medication: monotherapy of appropriate drug, increase dose gradually and adjusting with response, monitor for side effects, watch out for interaction with other medications. If response is poor, introduce another drug while withdrawing the first medication, and use polytherapy as the last resort. So like I said, it's daunting now to pick seizure medication because of the many types of seizure medications we have. Over time, we've had the first generation, the second generation, and the third generation anti-seizure medication, from bromide to diazepam, carbamazepine as second generation, clobazam, valproate acid, clonazepam, and the third generation in the 90s, where gabapentin was produced, lamotrigine, topiramate, osgapapine, levetiracetam. So in the early 2000s, when we had zonisamide, pregabalin, lacosamide, and recently brifaracetam, everolimus, cenobamate, and latest, the cannabinoids, which I'll also talk about briefly. So it's actually difficult now to pick, but we'll try to pick based on different reasons. But again, these are the do's and don'ts of epilepsy. There has to be drug compliance, no fasting or starvation, no alcohol or drug use, no all-night vigil, no climbing of heights or using heavy machinery because we don't want you to have a seizure in a height that might cause death. No driving, because most time when there is an accident and the patient sees, it's always the egg before the chicken or the chicken before the egg. If the seizure causes the accident or the accident caused seizures, it's always difficult to tell. And no swimming or bathing unsupervised, no cooking over an unguarded oven or fire. So like I said, choosing anti-seizure medications should be based on the seizure type or the epileptic syndrome. This is the first thing to consider because many anti-seizure medication treats only certain types of epilepsy and not others. So if you don't make the correct diagnosis of the epilepsy or the seizure type, you might find it difficult to treat the patients. And you have to look at the pharmacokinetic profile of the medication, comorbidities, the efficacy of the medication, the expected side effects. Gender is important, especially female of childbearing age, then the cost of the medication. Okay, the International League Against Epilepsy actually had a summary of evidence and recommendation based on the epilepsy type, with the spatial onset, that means focal, For adults, the evidence shows that carbamazepine, phenytoin, and levetiracetam is level A. That means they are known to be very efficacious. Valproate is probably efficacious, and the level C are the ones that are not very sure to be efficacious. The same thing for children, carbamazepine. Carbamazepine is also known. For elderly, the choice is actually lamotrigine and gabapentin because of drug-drug interaction for elderly. Then for generalized epilepsy, none of the drugs is actually level A, but for level C, we have carbamazepine, lamotrigine, oxcarbazepine, phenytoin, topiramate, valproate for adults. And for children, there's carbamazepine, phenobarbital, topiramate, valproate. And for absence seizures, etosuzumide, lamotrigine, and valproate. That's according to the International League Against Epilepsy. Again, these are their own drugs for the epileptic syndromes. But more importantly, this is one of the most important slides in this presentation. It might look very clumsy, but like I said, the most important thing about picking medication is looking at the epilepsy type. And if you know the epilepsy, if it's focal, the drug of choice is lamotrigine, levetiracetam, lacosamide, oxcarbazepine, and carbamazepine. That's the first line drug. But if any of these doesn't work, then you have alternatives. And the alternatives are topiramate, valproate, phenytoin, cenobamate, and phenobarbital. Now, if it's generalized tonic-clonic, then valproate is the drug of choice. That is if the patient is not a female of reproductive age. We'll talk about sex affecting the choice of medication. The other thing is levetiracetam. And if this doesn't work, these three doesn't work, then you can use topiramate, lamotrigine, or cenosamide. Now, if it's absence, drug of choice is etosuzumide or valproate. If these two doesn't work, then you can use levetiracetam or lamotrigine. For myoclonic, it's also for valproate and levetiracetam. For infantile spasms, prednisolone or vigabatrin are the drug of choice. And you also have the alternative if the patient reacts to this or this doesn't work. For Dravet syndrome, it's valproate, clobazam, or fenfluramine. If this doesn't work, then you can also go to ketogenic diet or cannabinoids. For Lennox-Gastaut syndrome, the drug of choice is valproate, clobazam. If this doesn't work, you can try levetiracetam, cannabinoid. The implication of this is that you must make an appropriate type of seizure or epileptic syndrome before you decide which medication to use, because some of them are epilepsy specific. Now, because this is an update, we should talk about the newly approved drugs for anti-seizure medication. Rifaxitin is recently approved for focal seizures. Cannabinoids, which is found in marijuana, has also been approved for some specific type of epilepsies. Lennox-Gastaut syndrome, Dravet syndrome, and tuberous sclerosis are the epilepsies that cannabinoids can be used for. Now, for Dravet syndrome, again, fenfluramide can also be used, and it's also under investigation for Lennox-Gastaut. Now, everolimus, which is an anti-oncogene, is used in oncology. It's also the drug of choice for TSC, that is tuberous sclerosis complex, and is the only drug that is actually known to be anti-epileptic, because using this drug can actually cure you from epilepsy. So it's apparently the only drug that can be called as an anti-epileptogenic drug. The other new drug is cenobamate, which is both a sodium channel blocker and a GABA inhibitor. It's approved for monotherapy and adjunct therapy for focal epilepsy. Those adjustments of concomitant anti-seizure medication is actually indicated. That is, when you are giving this drug, you must adjust for clobazam, lacosamide, phenytoin, and phenobarb. Now, we've talked about the seizure types, picking drugs based on the seizure type. Now, based on gender or sex, especially for women of childbearing age, the drugs can influence the hormonal function of female and pregnancy. So for hormones, anti-seizure medications that are enzyme inducers, like carbamazepine, oxcarbazepine, lamotrigine, and decrease endogenous hormones and exogenous oral contraceptive. This means that they can alter menstrual cycle, alter ovulation, and also cause failure of OCPs. Now, in pregnancy, you have to balance between the teratogenic effects of anti-seizure medication and maintaining seizure control. Some anti-seizure medication actually, their serum levels reduce during pregnancy, so you have to monitor them. Lamotrigine, levetiracetam, topiramate, oxcarbazepine, and stenozamide, their serum concentration reduced in pregnancy, meaning you have to measure their serum levels during pregnancy and likely increase their doses during pregnancy. Now, some drugs have been known to be teratogenic, and this chart or this arrow actually shows increasing risk of teratogenicity amongst anti-epileptic drug, anti-seizure drugs, I mean. So the safest is actually lamotrigine and levetiracetam. We call them low risk because you only have about 2 to 2.9% of patients that take the medication having abnormal babies. The other one is oxcarbazepine, gabapentin, and lacosamide, which is about 2.3 to 3%. It's also low risk. The medium risk is carbamazepine, topiramate, and stenozamide. The high risk one are phenytoin, phenobab, and primidone. And valproate is actually the highest risk of teratogenicity. And the teratogenicity also increases with the dose that you use. So if you have to use, it's actually a black box now. You are not allowed to use valproate in pregnancy. But if you don't have a choice, then you have to also reduce the dose because the teratogenicity increases with dose. Valproate, phenobarbital, phenytoin, carbamazepine, clozapam, and pregabalin, they also cause developmental delays and intellectual disabilities in children born or to patients, to women that use any of these medications during pregnancy. The next thing is age. And age, more importantly, we are interested in the elderly. Elderly are particularly a special population because they have multiple medical comorbidities going on when they have epilepsy. Adverse effects related to polypharmacy and pharmacokinetic interaction is actually important to be noticed. So enzyme-inducing anti-seizure medication like carbamazepine and enzyme inhibitors like valproate are generally avoided because of interaction with other medications. Then oxcarbazepine, eslicarbazepine are generally avoided because of high risk of hyponatremia, which can also again cause seizures in the elderly. Now, the drugs that are well tolerated by the elderly, if you have an elderly patient with epilepsy, it's better to start levetiracetam or lamotrigine because these are well tolerated. Now, by comorbidity, meaning there are other conditions that you have, and you have epilepsy, like depression. These are the preferred drugs. Valproate, lamotrigine, clozapam are preferred for depression, and you should avoid levetiracetam. For any patient you are giving levetiracetam, the patient you must first be sure that the patient doesn't have any psychiatric problem, because this worsens psychiatric problems. Now, migraines, if the patient has migraine, you can also use topiramate. That's killing two birds with one stone. You can use valproate, but you should avoid lamotrigine or oxcarbazepine. If the patient has tremors, you should avoid valproate, and you can use the topiramate, which can also be used to treat tremors. Now, if they are cardiovascular disorders, maybe MIs and other things, it's safer to use levetiracetam or topiramate and avoid any enzyme-inducing medications. Now, for hematological problems, you can use levetiracetam again. Also avoid enzyme inducers like carbamazepine or inhibitors like valproate. And the list goes on. Hypersensitivity, you should avoid drugs that can cause hypersensitivity like carbamazepine, lamotrigine, phenobarbital, and phenytoin. Now, what happens beyond anti-seizure medication therapy? Now, about 1/3 of patients with epilepsy will have drug-resistant epilepsy, meaning patients are diagnosed with drug-resistant if they continue to have seizures despite 2 adequate trials of 2 appropriate, chosen, and well-tolerated anti-seizure medication. That is, you must have tried 2 anti-seizure medication, and it must be appropriate. Not that you are giving ethosuximide for generalized epilepsy and it's not working. That is not appropriate. Or you are choosing valproate for a focal seizures. That might not likely work. So you must choose the appropriate one, and you must have tried 2 of them. Then you say the patient is resistant or he has drug-resistant epilepsy. So patients with drug-resistant epilepsy might benefit from surgery or neuromodulation or even diet. Now, there are some misconceptions we have about surgery. Everybody thinks all drugs need to be tried before you try surgery. No. Immediately you try 2 appropriate anti-seizure medication and the patient is still having seizures, then you must proceed to surgery. Again, people feel that if there is bilateral EEG spikes, meaning thinking that the epilepsy is from 2 regions of the brain, the patient does not need surgery. No, the patient needs surgery. Again, when they are normal MRI, it's not a contraindication. Like I said, you might have to do functional MRIs or functional investigation to look for the area of the seizure. Then if they are diffuse or multiple MRI lesions, it's not also a contraindication, because you can have multiple lesions and they might not be the sites where the epilepsy is coming from. Again, surgery is also possible when you have it in the primary cortex. If the patient has memory problem, you can still do surgery. If there's chronic psychosis, surgery is still not contraindicated. So surgery should be thought of immediately. You have tried 2 appropriate anti-seizure medications and the patient is still having seizures. Now, what are the seizure epilepsy surgery? You can have a resective surgery whereby you restrict the part of the brain that is causing the seizures. You can do a laser interstitial thermal therapy. There can be a stereotactic radio surgery whereby you do surgery and do radiotherapy at the same time. You can do corpus callosectomy whereby you dissect the corpus callosum. You can do hemispherectomy whereby you remove the whole side of the brain that is causing the seizures. The other thing you can do is for patients that are not fit for surgery, there's what we call neuromodulation, whereby you can do responsive neuromodulation or deep brain stimulation or vagus nerve stimulation. This stimulation, immediately there is going to be a seizure. It aborts the seizures immediately. So this is what this neuromodulation does. Now, it will not be appropriate to talk about epilepsy without talking about status epilepticus, because it's a neurological emergency. And what is status? Status epilepticus means that the patient it's time defined. You have seizures for more than 5 minutes, or that is the motor component, and you are not recovering. Or you have 10 minutes of a focal seizure that is not recovering, then you're in status. And treatment must be immediate so that it doesn't cause damage to the brain. So the first line treatment is actually benzodiazepines. And that's what we use to abort people with seizures. Most importantly, lorazepam, diazepam, or midazolam can be used as the first line. Now, if the patient is not recovering from the seizure after this first line medication, or the seizure stops but is not recovering from consciousness, then you have to go to the second line. That means there is an established status epilepticus at this point, or what we call benzodiazepine refractive status epilepticus. And at this second line, you can use phenytoin, you can use levetiracetam, you can use valproate at the second line, and they must be intravenous. But in this environment where levetiracetam intravenous is not available, you can actually pass an NG tube for the patients and load the patients with levetiracetam tablets, as much as 3 to 4 grams. If the patient is not responding after this, and it doesn't recover from the seizure, then you are at the stage of what we call refractory status epilepticus. And at this point, you need an IV anesthetic, and this patient must be managed in the ICU. And at this point, you can use thiapental, you can use phenobarbital, or continuous intravenous midazolam. That means this patient is in refractory. Now, the patient doesn't still recover after 24 hours, despite anesthetic agent, then this patient is in super refractory status epilepticus. And at this point, you can now try steroids, you can try immunoglobulin immunoglobulins at this point. So what are the consequences of uncontrolled epilepsy or uncontrolled attacks? There are biological morbidity, there can be torpor, there can be transient paralysis, there are psychological stress that come with it, there are medication side effects, there are social mobility, stigma, poor education, poor self-esteem. And there can also be economic consideration, whereby there's job limitation, medical expenses, or the patient outrightly loses his job. Now, the prognosis, 70 to 80% of patients will achieve seizure control when the therapy is early and there is compliance. Again, for benign epilepsy, meaning epilepsy that recover with age, or acute symptomatic type will recover. 10 to 20% of patients actually do not have seizures, and what they have is seizure mimics. And 10% of patients will actually have refractory seizures, meaning drug-resistant epilepsy that might need surgical intervention. Thank you for listening.
Thank you so much, Dr. Zubair. That was excellent. Thank you so much. Really appreciate that. I don't know if we're on the call, we can respond with a with an emoji. Thank you very much, sir. So we would go into the question and answer period now. Dr. Jacob is still on the call. So you're on the call. We've given everybody access to be able to unmute their mics. So if you would rather put it in the chat, you can put it in the chat. But if you want to speak, you can please raise up your hand first so that we can go in an orderly fashion. So I think so that while we're getting ourselves together, I would like to ask the first question on behalf of Dr. Samuel Amao, and I believe this goes to Dr. Ajikun. And his question is, what is the role of the measuring device in the accuracy of BP measurements? Dr. Ajikun, are you still there?
Yes, I'm still here.
Yeah, so Dr. Samuel Amao is asking, what is the role of the measuring device in the accuracy of BP measurements? It seems a bit vague. I don't know if you understand what he means.
Yes, if I understand him well, does the kind of measuring device you use affect the accuracy of your blood pressure measurement? And the answer is yes. If the recommendation is that now we use electronic devices that are measured on the arm, we do not recommend the use of the forearm gadgets, the use of the ankle gadgets and those things. No, so the arm measurement, then the size of the cuff is important. It should cover at least about 80% of the arm circumference. So we have the small, the medium, that is the standard, and then the large cuff size. So depending on the physique of your patient, you need to select. If you use a small cuff for a well-built person, is going to give you a falsely high blood pressure. And because it is electronic, you also need to make sure that the battery is working well. If the battery is low, it is also going to affect the blood pressures you get. Thank you.
Thank you, sir. I hope that answers your questions. Dr. Zubair, we have a question for you. He says, what is your take on epilepsy and driving, as the rules appear fairly black and white? So, Dr. Zubair, do you have any thoughts on epilepsy and driving?
Well, yes, I do. So the rule is that if you have epilepsy and you're uncontrolled, you shouldn't drive. Is it do not drive? There is no, ideally, if a diagnosis of epilepsy is made and you have a driving license, you are supposed to be reported and your driving license withdrawn. Now, there are specific cases whereby you have been controlled for about 5 years, and you can be allowed to drive. Or you have focal epilepsy and you've been controlled too for about 3 to 5 years, you can be allowed to drive. The other people that are also a caveat are people that only have nocturnal epilepsy. That means epilepsy that happens only in sleep. They're a group that can be allowed to drive. But ideally, immediately there is epilepsy, because it's the safety for you and the other road users. There was a study that shows that most accidents actually is caused by seizures. You say, why is this man driving off the road? He's actually having a seizure before that happens. So he's actually to not drive. Thank you.
Oh, thank you, sir. Thank you, sir. Dr. Brad, the another question for you says, what is the relationship between autism and learning disabilities and epilepsy? So is there a connection between autism, learning disabilities, and epilepsy?
Yes, there is. There's a group of epileptic syndrome whereby you have that we call developmental encephalopathies and epileptic encephalopathies. Now, for epileptic encephalopathy, that means the seizures appear early in childhood, and because you have multiple seizures over the years, the development is affected. That means you don't develop well. Now, there's the other one that is called developmental encephalopathy. Because your development is abnormal, that's when you start having the seizures. Let me take it again. Epilepsy causing the brain not to grow well, or the brain didn't grow well and it's causing epilepsy. Now, the other caveat is medication during pregnancy. Like I mentioned earlier, there are some medication you use in pregnancy that have been associated that the babies will tend to have poor developmental or intellectual disabilities, or even autisms. Valproate is a culprit. So those are drugs drugs in pregnancy, and if you have epileptic encephalopathies, you can also have learning difficulties.
Thank you, sir. Okay, there are no more questions in the chat, but please feel free to unmute your mic and ask your question. But please raise up your hand first so that it can be orderly if you still have questions. We don't seem to have any questions. We don't seem to have any more questions. Okay, this is interesting. So I think you're okay. Angela has a question. Okay, go ahead, please, Angela.
Okay, thank you, Dr. Zubair. So my question, or rather my thoughts, is around epilepsy, stigma, and also the stigma, especially with epilepsy. What is the Neurology Association doing in terms of, because honestly, you don't really hear a lot of noise about epilepsy, like the way you hear about malaria, tuberculosis, and you know that's the same way tuberculosis was before, you know, a lot of noise started happening around it and people stopped the stigma. But with epilepsy, you rarely hear things around it, especially in the media. So what are we doing for these patients in the community and, you know, generally? Thank you, sir.
Well, that's a very fair question. We are doing a little and we are doing much. I can say that there are different foundations actually for epilepsy, and they're actually good. There are some. It might not be enough. It's never enough anyway. And then there are still times that patients don't want to come out that they have epilepsy because of the stigma. Like I said, people still feel it's a demonic possession. I can tell you, just last week I had a clergyman with epilepsy, and all the while he was having it, they felt he was speaking in tongues. I had a child one time that was always beating a teacher in school. This was about 10 years ago. A specific teacher, it happens almost every time, and they felt she was demonic. And they sent her out of school. The mom never believed it was epilepsy until she came down with the generalized tonic-clonic. And they had to send her out of home. So the stigma is actually there. And there are foundations really that are trying hard, at least. There are different foundations, and there is actually a pink day, an epilepsy day in May, where we celebrate Epilepsy Day and try to at least go to the media and tell people more about epilepsy and the stigma and the way I'm actually more interested also in what happens when the patient is having a seizure and what people actually do. You see all sorts. You see different things that actually cause more harm to the patient than even the seizure itself. So I can tell you more can be done. We're looking for more people to join us to speak for people that can't speak about epilepsy, really. Thank you.
Thank you, sir. Over to you, Sam.
Okay, since we have not gotten any more questions, I think this is a compliment to Dr. Zuberi and Dr. Jacob. Means that it was well delivered. Well delivered. It was well delivered. Yeah, it does happen when it's well delivered and it's a good refresher. Please, I really hope that all of us on the call will use what we have learned today in our practice. Let us use it for our patients. Let's not forget that this patient who is someone's father, someone's mother, someone's child, and the doctor somewhere could also treat our own relatives the same way. So it's very, very important that we use this knowledge, not just for the CME points, but actually use it for our patients. And we really trust and believe that you will use it. So if there are no other questions, I think I'll just like to say finally to appreciate the speakers very much, very deep and heartfelt appreciation. Thank you so much, Dr. Jikum, Dr. Zuberi. Thank you so much for your presentation. Really appreciate it. It was well delivered and we've learned a lot. And we look forward to having you even teach more to the GPs in the future. So thank you very much. Yeah, even the comments are coming in and people are appreciating your presentations. They're saying they're very well too. Yeah, so that's a confirmation. So, dear doctors and colleagues on the call, thank you very much. Tomorrow we will reconvene again by 5 p.m. and 5 p.m. Nigerian time or 4 p.m. Ghana time. Tomorrow we'll be talking about febrile illnesses in pediatrics. This is very, very important. Every GP would see a lot of febrile illnesses for their patients coming in. And then we'll also be talking about diabetes and its ocular complications. Also very important for us. We'll see this is a common thing that occurs commonly in our setting. So please be around by the time. The room will be open again by 15 minutes to the time for us to join freely. And it's also be a great time tomorrow. So thank you all very much. Have a wonderful night rest and I'll see you tomorrow by 5 p.m. West African time. Have a good night. Bye.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye, everyone. Thank you,
Bye, everyone.
sirs. Bye.